So our next speaker is Rachel Nugent, who is Senior Research Scientist in the Department of Global Health at the University of Washington and Director of the Disease Control Priorities Network. She was formerly Deputy Director of Global Health at the Center for Global Development, Director of Health and Economics at the Population Reference Bureau, Program Director of Health and Economics Programs at the Fogarty International Center of NIH, and Senior Economist at FAO. She was a member of several committees, still is, and of key publications in the area of chronic diseases. Currently, Dr. Nugent is chairing a project that is of much interest to the topic of today's seminar, a project called Healthy Agriculture, Food and Non-Communicable Diseases for the Chicago Council of Global Affairs. I hope she gives us a few highlights from this, but also her views on the topic of linking agriculture and NCDs. Thank you.
Just a second.
Professor Lang hear me?
He can hear you and see you.
Without heavy breathing?
Yes, yes. Hopefully so.
Okay.
I believe this is yours.
Yep.
Okay. And then you can just click through.
Okay, thank you. Thanks very much, Marie. And Professor Lang, you were muted, not mooted, just so you know. You're a hard act to follow, a pioneer and a visionary in this field. And try as I might, I couldn't disagree with a thing that you said. So I don't know if we'll have much debate about things today, but we sure will have an interesting discussion. And I feel so old-fashioned standing here in person. Everybody else coming in from places around the world. But good afternoon, everyone. And thank you very much, Marie, for the introduction, for inviting me to speak today. I kind of feel as though I've come to a cathedral to talk about how to worship God. IFPRI really invented this topic. I mean, yes, there has been a lot of work done over many decades on non-communicable diseases. They are not new. And some of the original work that was done in the 80s was done by my colleague Dean Jameson, who was at the World Bank at the time, and early country reports that the bank was putting out, and especially in Asia, were showing the demographic transition and the other transitions that accompanied that were presenting some very serious threats to health systems and health budgets. So we learned some things then, and we're relearning them now, I suppose. I've been interested in this topic since returning from FAO, where I was working on a number of things, including urban agriculture, which certainly needed to be thought of in a very interdisciplinary way. And we tried. I won't say that we got really far with that at the time, but urban agriculture has also experienced a certain resurgence in recent years. So maybe if we wait long enough, all these things will come together and we'll have some solutions. I came back and I started working in global health then, about a decade ago. I began reading Michael Pollan's work. I always found it interesting and entertaining, and I think he had a lot of good questions to ask in the popular media, and raised awareness of issues of food and their relationship to health. In the popular media, I don't think he had a whole lot of answers. I think it's up to places like IFPRI and Professor Lang and others to come up with some good answers, the idea of evidence base for policy making and for action. So let me give a little bit of my perspectives, and I will talk a little about the project that I've been working on that will be released shortly at the UN meeting. Here is a very telescoped and abridged intellectual history from my own perspective. It doesn't go as far back as Professor Lang's, but based on my own experiences largely at FAO and at NIH, and I hope it's not too small for you to read. I think there was a first generation of agriculture and health research that produced some very excellent work, but it was a relatively small number of researchers, a relatively small number of topics, things like the toxic exposures in water, soil, food residue, things like worker exposures to pesticides. People will remember the BSE scare and the policy response, particularly in Europe, to that. H1N1, et cetera. So there's a long history of work connecting agriculture and health, but not to NCDs. It's very, very specific health outcomes that were being studied, and it didn't answer the kinds of questions that we need to have answered now. Then what I'll call the second generation, I think really was started by, well, let me back up just a second. The second bullet there mentions in the nutrition, because nutrition is a real key component of this, obviously. In the nutrition world, there's a very deep and rich history, of course, looking at individual micronutrients, looking at food insecurity, protein, energy insecurity, and longitudinal research that connected nutrition to economic outcomes, some of which I funded when I was at NIH. So again, I think there was a very interesting work being done, not really looking at NCDs at all, non-communicable diseases, and I'll use the term NCDs for shorthand, but building up something of a knowledge base, something for us to draw on, and keeping alive at least a small community of researchers here and there looking at these issues. IFPRI's work, what I would consider the second generation really, CGIAR and IFPRI, got started on some very good work. There was a series of briefs produced. My recollection is in 2002 I had one. There were many topics covered in that series of briefs back then, and then later the research platform expanded, and at several of the CGIAR centers, again, some very nice work, but it was very difficult to get it funded, and it really didn't take off, as it were, at least into the NCD space. And then more recently, I would say, of course, that the IFPRI conference in New Delhi this year would be the beginning of a third generation, and that there really was attention. Marie acknowledges, I think perhaps maybe overstating a bit, that NCDs weren't central to that. Everyone in the room probably knows more about the conference than I do. I wasn't there. But there was a lot produced. I've read a lot of it. And people knew about NCDs. They talked about it. A lot of people came with that on their minds. So I think that broader conception really was present in New Delhi. And now we're looking at this conference coming up at the United Nations in a couple of weeks, which I'll talk about a little bit more. The New Delhi conference, 8 papers, 21, I won't get the numbers right, 21 briefs, 12 plenary sessions, 14 side events, an online quiz. I could go on, and if Red Jewel's in the room, she must be exhausted still. But it really did accomplish something that needed to be accomplished, and I think it's now our task, and I hope our motivation to go from there and begin to build these relationships, as it were, across the sectors. I was asked, before I go on to the high-level meeting, I was asked to talk about linkages here, and so here are some linkages. I don't think that it's really blurry. Sorry, I think I copied it from an early copy that I had, and we'll have a better, newer, updated version in the report that's coming out very shortly that you'll all have access to. But very, very briefly, here are some linkages. The connections between nutrition and health are obvious. There are also close connections between agriculture and nutrition, and between agriculture and health, along with all of these underlying drivers that you sort of see on the bottom. You probably can't read very well: environment, policy, natural events, technology, and onward. This is a very stylized view of these drivers and influences on agriculture, nutrition, and health. This kind of thing can come in many different versions. Some might have seen the great spaghetti diagram that was in the Foresight, the UK Foresight obesity report, and that only covered, it was enormous, and it only covered part of what we're talking about here in terms of whole food and ag and health systems. So everybody in the room probably has a picture of something like this in their mind. What are the linkages among these key sectors, if you will, or subsectors, and all different permutations of that? But that's what makes it so difficult to sort out the causality. And in fact, one of the challenges of researching in this area is that it's very hard to assert things about causality. Is Michael Pollan right about agricultural policy being a major driver of ill health here, or does eating behavior and do eating behavior and income have much more impact on health than agricultural subsidies do? And what can farms do about these things? There's many, many different kind of causal questions that we are asking and should be asking. it's hard to give answers to policymakers. In the poorest countries, and here's where I think one of the biggest challenges of working in this area is this, seeming dichotomy between how it plays out in the poorest countries and how it plays out in the rest of the world. That's the dichotomy that I think for many people at first glance means that the NCD thing is a rich country problem that they needn't worry about if they're working in development, if they're working at agriculture development, global health development. The ag sector drives the economy in the poorest countries, of course, and nutrition generally improves with per capita income growth up to a point. In other countries, that relationship is even harder to characterize. Lots of buts, and for these people and for those people, this, that, and the other thing. But generally, ag is more driven by the forward linkages to food, nutrition, and consumption, as well as policy. With access to more food, both better quality and worse quality food, nutrition can worsen and then it can improve. I'm speaking about sort of the socioeconomic gradient and how nutrition and health change as that socioeconomic gradient changes. But of course, in any country, in any population, you'll see a lot of variation as well, even in the poorest. So it's hard to characterize and to talk about this in a very simplistic way, and it shouldn't be talked about in a simplistic way. Where do we stand now? Just briefly getting to the meeting. The reason that we're looking at linkages is to try to break down those steps in the process and consider where there are opportunities for change and how to achieve it. That's what New Delhi talked about. That's what a lot of work at IFPRI does. It's what I'm thinking about. A lot of these links are familiar to us conceptually and not well measured, and I'll talk a little bit about more detail in a few minutes. But in terms of where we stand now, the cross-sectoral connections are recognized in the abstract, but in practical policymaking, we're still stuck with these silos and these vertical programs and these sort of segregations into disciplines. And so I hope that after the presentations, we'll have a conversation here about what can be done, especially with the health perspective in mind, because knowledge from agriculture and nutrition and what many of you folks are doing has to get into the health sector in a more deliberative way, in a much more engaged way. Interestingly, at New Delhi, according to the survey that I read, participants felt that joint decision-making between agriculture and health would be the best way to go, a better way to go than having them be separate sectors. Not everybody felt that, but a lot of people felt that. So moving on to where we are now, I've mentioned the IFPRI conference enough. I think already there are a number of things that have begun to change the conversation. You're more in touch with that than I am. On the health side, where I tend to reside, the high-level meeting is intended to raise awareness, to propose actions to prevent and control NCDs, and to engage a broader array of stakeholders. That last point, which is very much a part of the resolution that called for this high-level meeting, it's very much a part of all of the sort of official UN papers that have been put out. It is just not happening. I think where we are is that this is beginning to build a community. New Delhi was a part of that. The high-level meeting in 2 weeks is a part of that beginning, but they're not really on the starting block together. I gather there were about 15% of the people in New Delhi that were from the health sector, which seems pretty good considering that you weren't deliberately going out to bring those people in. At the high-level meeting, there are virtually no agriculture people, as far as we can find out so far. So two clear messages that emerged from Delhi and I think are part of the preparation for the high-level meeting, that different sectors want to work together more closely, at least give voice to that desire, and that the downstream sectors, nutrition and health, believe that agriculture has huge influence over their outcomes. And that's one of the points that Professor Lang raised that I think we'll want to come back to. A little bit of background on the high-level meeting and the NCD issues. This is what global health people are looking at. The advocacy began amongst a relatively small group of countries, principally the CARICOM countries, back in 2007. Civil society organizations, the International Diabetes Federation, and other international professional health associations created coalitions after much debate about whether they should go it alone and pursue diabetes and heart disease and stuff separately. They really came together in a coalition, which was quite path-breaking. I think in part the contrast between the lack of attention to NCDs and the skyrocketing attention and funds to the communicable diseases sort of spurred the effort. It just seemed so out of proportion when you looked at the statistics in global health about what people are dying from and where the money was going. So it happened, the meeting happened rather suddenly. I think most people in the NCD community didn't expect the UN to agree to hold a meeting like this so quickly. And there are expectations about it, although I think those expectations are dropping by the day, maybe by the hour. There was a lot of discussion early on about the AIDS meeting, the HIV/AIDS summit, if you will, the UNGAS held in 2001, and how this could be a repeat of it. It's only the second ever UN meeting high-level meeting on health. Those expectations have certainly gone away if they ever were real. There's still a very low level of funding for NCDs, and there's some little hints here and there that there are going to be some announcements and some increase in funding. But a lot of countries in the world do not rely on donor funding. It is up to them to decide how to spend their funds and whether to address this. Those that do rely on donor funding, by and large, still face these double burdens that we can talk about, and we have talked about, and it's very difficult for them to talk with their donors about NCDs because of some of the perceptions surrounding NCDs. So it's not going to change overnight by any means. Very, very briefly, because I think you probably are familiar with the problem largely, but I wasn't sure how much background you'd have. You've seen the statistics and heard the statistics from Marie and Professor Lang. In terms of nutrition, which again is so key to this, well, let me mention first the age standardized death rate. I'll show you a graph in a moment. That's one of the differences in developing countries compared to developed countries and how this all plays out, that these diseases hit people at a younger age in developing countries. Let me just, there we go to that. Sorry to flip ahead here. But you can see just in a few countries that we've looked at fairly closely, the age standardized death rate per 100,000 deaths from NCDs. You can see for males and females, the death rate at a given age is much higher in the lower income countries shown here compared to middle income or high income. And as Marie said at the outset, 80% of these deaths in the world are happening in low and middle income countries. Of course, they have higher populations and less health care. There's a lot of reasons for that, but lots of people are dying, and they're dying at a relatively young age from these diseases. Let me go back just for a moment to a couple more points I wanted to make about nutrition. So a lot of these diseases are driven by nutrition. Of the risks of mortality in the study in 2000 that Azadi and all published in The Lancet, 9 out of the top 20 disease risks related to nutrition. And of those, half of them related to what we'd call overnutrition, and the other half related to undernutrition. Now, that everybody in the room, I'm sure, knows it's very difficult to attribute risks, and nutrition is particularly difficult. But again, I think it underscores the point that we should talk about malnutrition and talk about some of the common drivers and common solutions, and that's not really happening. And I guess I would support Professor Lang in saying IFPRI and a lot of the places where many of you probably work are the place where that conversation has to start and be really supported with good evidence. This is the U.S., so this is not a developing country. New data from the Global Burden of Disease Project that'll be published later this year is going to give you this kind of information for developing countries as well. It's a huge project that is just culminating with publication later this year. But just for the U.S., it's so interesting to see the very advanced state of the epidemiological and nutrition transition playing out here, where you can see almost all of these disease risks, so the deaths attributable to these particular risks, are all related to poor diet. And then you can see in terms of the color or hatch mark of those horizontal bars, which diseases the dietary factors relate to. What are people dying of that poor diet is contributing to. And again, this is the US, you would expect it to be very, very advanced, but interestingly, when you see the statistics for developing countries, you will also see that these kinds of risks, the salt, the trans fatty acids, the saturated fats, low fruit and vegetable intake, those kinds of things are creating these biomarkers of high blood pressure, high blood glucose, high cholesterol that then cause people to die of these specific types of diseases. I think you'll maybe be surprised how widespread it is. Again, I don't know how much you can read that. These are some of the bottom line conclusions from the dietary risk group for the global burden of disease. In case people don't know, the GBD folks, the global burden of disease people, are the folks that bring you the DALYs. Thank you, GBD. The disability adjusted life years, what are the losses in terms of premature mortality and illness caused by different diseases. So they've just completed a huge new review in nutrition as well as in all other disease and health areas. I said it'll be published later this year in The Lancet. Here are some of their conclusions from looking at nutrition. Dietary quality is very important. It's a major risk factor, independent of obesity and calories. For chronic diseases, it's best defined by food and diet patterns, not individual nutrients. Existing global data, not surprisingly, is very limited, but they looked at literally tens of thousands of studies, individual surveys and studies. And they will be able to say some things about the causal effects of major dietary risks and give information on dietary intake and impact on chronic diseases. And so what I showed you for the US, as I said, will be able to be seen for a broader array of countries. And the hope is, of course, that this will inform priorities and policies for prevention of these NCDs. Let me go on to very briefly on the economic side. So shifting to the economic costs, in addition to the double burden of disease and malnutrition that we spoke about a bit, people experience NCD mortality at earlier ages. I showed you that chart. This has serious implications for the economic impacts. There's lots of studies now being done. This is kind of a new field in global health economics, but lots of studies are being done to try to measure the impact of NCDs. And here's just a few. On the left-hand side, this is on obesity. It's not a disease outcome, but it's obesity in China. Total costs related to overweight and obesity are 4% of the country's GDP, projected to reach 9% of the country's GDP by 2025. Moving over to the right, on diabetes, a recent study shows that health spending on diabetes ranges from 6% of all health expenditures in China to 15% in Mexico. Moving over to CVD, cardiovascular disease, a new study not yet published by Louis Neeson et al., Louis at Johns Hopkins and ICDDRB in Bangladesh, working with the centers of excellence that are funded by NHLBI, found that full implementation of a package of cardiovascular disease prevention would cost $7 up to $30 per capita, depending on the country. And the total estimate for prevention in the 18 countries they studied, roughly 111 billion. Just to put that into context, for the full CVD prevention package, national health expenditures would have to go up by 5% in Latin American countries, 10 to 20% in other LMICs, and 76% in the poorest settings, just to be able to provide that package to people. I mean, obviously, it's not affordable. And then finally, on a yet unpublished study that David Bloom and colleagues at Harvard have done that'll be released for the high-level meeting, they're estimating more than 30 trillion in full economic costs from NCDs globally. So let me, just a couple more slides and let me close then. The bottom line on that is that health spending alone is not going to solve this problem. We need to turn to other sectors, other kinds of interventions. The food system needs to offer choices for a healthy, balanced diet. There's a wide range of actors, and as Professor Lang was suggesting, when we move from agriculture rightward along that spectrum of the supply chain, there are a lot of opportunities we need to be able to work with those actors to find opportunities for improving the healthiness and quality of the diet. And it's not just diet, it's also where food is delivered. So in the report that will come out soon from the Chicago Council, we talk about the value chain. A lot of work has been done here at IFPRI and elsewhere on food value chains, on how to increase efficiency of the supply chain. We need to engage the people who are doing that, logistics experts and others, to look at how to find social, environmental, and health goals in that process. We also need to find how to align health and agriculture with what I call mutual metrics, progress indicators that can be used by both sectors together. And we reviewed a number of major agriculture and health donor initiatives, including Feed the Future and the Global Health Initiative here in the US, and found a great deal of overlap in the outcome measures being used. There's a great deal of potential there for mutual metrics, and that's part of aligning for better health. Finally, just messages for IFPRI in terms of more research. This could be a very long slide, but here's some of them. There's quality and diversity of diet. Marie and colleagues have worked a lot on this, and as she well knows, we're still looking for the holy grail on measuring quality of diet and diversity of diet. There have been studies done, but it's far from a full picture. Options for food reformulation and changes in food processing. Causal linkages. Colleagues at the Leverhulme Center in London have recently done a systematic review. I'm involved in that. They found only 3 studies that had analysis of the linkages across agriculture, nutrition, and health outcomes. 3 studies that really were analytical studies with empirical work that spoke to those linkages. And they started with 14,500 papers. So policy options, the impacts of policy, of course, the impacts of subsidy. There's a great debate about the impact of subsidies on price and therefore on nutrition and on health, and of course the relationship to poverty, because to get donors and development communities interested, we need to show much better how it's related to poverty. So with that, I thank you very much.